Thank you, everyone, for joining us. I'm so happy to welcome you back. I'm Andy Biggs from Arizona's 5th Congressional District, and I am so pleased and feel so fortunate to be able to have with me today a special guest, and Dr. Bhattacharya. Is that pretty close anyway?
That's pretty close. Yep, no worries.
Bhattacharya, okay. Who is, not only is he a doctor of medicine, but he is also a PhD in economics. And quite frankly, he's has been one of the most engaging people I've talked to in a while, and very bright, and has looked at this virus issue very closely, both from a medical perspective and a statistical perspective as well. So one of the reasons I wanted to engage him to be with us tonight is because he was quoted in a piece talking about the case fatality rate for the COVID-19 virus might be by orders of magnitude less than many of the models had predicted. So with that, Doctor, if you wouldn't mind just kind of, let's take it up from there.
Sure. So I think the original forecasts about the fatality rate, or the case fatality rate, as it was called, so were around 3%. The World Health Organization famously put out a report very early on in the epidemic saying that the mortality rate is 3.4%, meaning that if you are infected, and you're identified as having been infected, then 3 out of 100 will die, which is an enormous number. I mean, that's a very, very, very deadly disease, if that's true. It warrants a very, very, a huge public health response. The problem is that number assumes that you know how many people have been infected. And in fact, at that time, almost all of the testing, in fact, all of the testing that had been done on a public scale had been testing that focused on whether you actively had the virus present in you. Because the test for the virus that they were using, and people still use, and it's a good test for clinical purposes, but it just checks if the virus is there. But for most people, the virus, you get it, it's like a cold virus in that sense. You get it, you clear it, and it's gone. It's not like it lives inside of you forever. So all these people that may have gotten it that cleared the virus weren't counted in the denominator. Right, so the death rates, the numerator, number of deaths, denominator, how many people got it, and we were only counting a portion of the number of people that got it. So what I've been working on is trying to measure that denominator, to measure how many people in the population actually have evidence of having had this infection. And the way I've been doing that is I've been working with a lot of really, really bright people to count the fraction of the population in various areas that have antibodies to the COVID infection. So if you get infected, you're going to produce an antibody response. I mean, that's just the nature of how we deal with any virus. And those antibodies last. And if I can get an antibody that's specific to the virus and that isn't triggered by other viruses or other things, then I can get a pretty good count of how many people actually have had the infection. So when we've done that in Santa Clara and Los Angeles counties, what we found is that many, many, many more people have had the virus than you would get from just counting the people who actively have the virus, the case reports. Like in Santa Clara, 50 times more. In LA, 40 times more. So it's 30, I mean, there's some numbers, a range of numbers, but that's the first order thing. If you do that, so that means like for every person that we've identified with the virus actively having it in you, there's 49, 50 other people that are walking around that have had the virus that were never had the PCR test, never showed up, probably didn't even show up for at a doctor.
They may have been totally asymptomatic.
Yeah, they could have been asymptomatic. I mean, what's clear is that there's a range of presentations, ranging from basically no symptoms at all, mild cold symptoms, all the way to this horrible viral pneumonia that kills you. And what we're seeing when we look at the viral pneumonias is just the tip of this deep iceberg of cases, most of which look for all the world like mild cold symptoms. But of course, unlike mild cold symptoms, unlike a virus that causes mild cold symptoms, it can kill you. It can actually result in this horrible viral pneumonia. It's a deadly disease. I mean, you make no mistake. But once you account for that denominator, what you get is roughly, instead of 3 in 100 deaths from getting the virus, it's more like 1 in 1,000 or 2 in 1,000. Now now that number, that 1 to 2 in 1,000, is not a biological constant. It's a function both of the biology of the virus and also the circumstances which are treated. So, for instance, similar studies in New York have found that that number is more like 5 in 1,000. But in many, many, many other places where similar studies have now been done, we're getting a very similar number. I think in Denmark they found less than 1 in 1,000. In Germany, I think it's somewhere on the order of 3 in 1,000. In a host of countries, they're finding a large number of people. In Kobe, Japan, they found 500 to 1, 500 cases for every one that they identified. It's very clear that there's a large number of people that we have not been identifying that have had infection that make that fatality rate much lower than realized.
So, doctor, just to make sure I understand, leaving off the denominator, which is really hard to identify because we simply don't know. But the estimate originally was that you would have basically 3 per 100 or 30 per 1,000.
Yeah, 30 per 1,000.
But what we're finding is it looks more like it's between 1 and 2, maybe even less than 1 per 1,000.
It depends on where you are. So, like in New York, maybe 5, right? So I think, I think that 30 to 1,000 versus 1 in 1,000 is a vast difference in how we should react to or think about this, right? So we are exposed to risks all the time on that order, and we have to learn how to manage those risks. I mean, like you could be infected with Haemophilus influenza. Right? I mean, if you could be infected with measles. We learn to react to those risks by scientific work to try to mitigate them. Like in measles, we have a good vaccine. We take precautions to avoid putting ourselves in condition to have those risks. We don't generally shut down our economy over a 1 in 1,000 risk.
Okay, and so, real quick, I think this is related. I want to make sure that we get a feel for this. There's been some reports recently of 2 different studies, one out of Marion, Ohio, a state penitentiary there, and then I believe there's a federal penitentiary in Tennessee. And both of them indicated a very broad spread within this very closed environment of those who were in prison. And so you've had a chance to look at Marion, is that right?
Yeah, so I've looked at some of the data from Marion. It's incredibly interesting. So there they did, I think, if I understand correctly, they did PCR testing. That is, whether the virus is actively in you currently. And they found a very large fraction of the inmate population there had active infections. But most of them were completely asymptomatic. And as best I can tell from the data, there were no deaths, at least up to the time of the report I read. Right. So it seems like in that population, a very large fraction of them were in the range of mild to asymptomatic, and very few in the severe viral pneumonia bucket. I mean, as I said, I think the typical presentation is that, like I said, 50 to 1, relatively mild presentation of it.
Yeah, and so we look at a typical prison population is going to be usually 18 to 50, and so that might have some kind of we wouldn't say necessarily causation, but certainly correlation. Age must be a very strong variable in how severe, I suppose, the disease manifests itself.
I completely agree. I mean, that seems really clear from the data, right? So if you're older, that's the population that has the higher risk of dying, getting a more severe presentation. Now, just because you're older and you get it doesn't mean you're going to get the severe presentation. You may still get less severe presentations, but you're more likely to get the severe presentation if you're older. And if you look at the data about deaths, it's I think a very, very substantial fraction are above 65 or 70 who die from this Actually, it's not just the age, but also the circumstances of where you're treated, right? So I think a large fraction of the population that have died from this in the United States are actually nursing home residents, long-term care, and other residents. So it's in places where, in fact, I think the very earliest evidence of among the very earliest evidence of spread in the U.S. was a nursing home in Washington State, where a large fraction of the population got it, and many passed away. So I think if you're in a situation where there's high viral load, lots of people have it, it's difficult to isolate people, and it spreads, like in nursing homes, I think in New York and Washington State, all over the country, where nursing homes really seem like a locus of danger for this virus. As I was saying earlier, it's both the biology of the virus and the circumstances of treatment together that create the fatality rate.
So one of the things that I've looked at that anybody can look at, I mean, it's on the internet, it's got to be true, but I mean, there's reference places telling us on the case fatality rate, or I should say fatality rate per million of population within that nation. So for instance, you would look at it, and the U.S. is somewhere around, I want to say 185 per 1 million of citizens will pass due to coronavirus. Oddly enough, that's the way I read it. It was perhaps one of the lowest in the entire industrialized world, and next to it was Sweden with just under 200 per 1 million. And so, with regard to Sweden, Norway, other Nordic countries, maybe I'm wrong, but it seems to me that a rational data point is the deaths per million residents or citizens. So,
and of course, yeah, I mean, the U.S. has had a much more strenuous lockdown policy than Sweden has. Sweden famously has had a very relaxed policy toward the virus, although not completely relaxed. There's still social distancing. There's still no gatherings above some number of large number of people.
I think it's 50, Doctor.
Yeah.
Yeah. So so when you compare it, Sweden to Norway, have you looked at any numbers there to give us a point of comparison?
Yeah, I mean, I have looked a little at that. So I mean, it seems clear that the lockdowns in Norway have contained the total number of deaths up COVID-19 up to now, relative to Sweden. Right? Sweden has a higher death rate than Norway does.
And what is I guess what those two very disparate approaches, quite frankly, what's the long-term impact? We've heard about rebounding of a COVID virus in the fall. I mean, how does this either side play this out?
I mean, so let's think about the disease models. There's no vaccine. There's not, even in Sweden, I don't think anywhere near herd immunity. If you lock down, you slow the spread of the virus because you reduce the number of interactions between people that might cause the virus. The lockdown is not a policy that will eliminate the virus. All it does is slow the spread for a little while you're locked down. When you lift, the virus continues to spread. It's not the policy is not disease eradication. In a sense, we have to learn to live with the virus, just the same way we learn to live with every single other infectious disease that we've ever faced. I mean, it sounds like hard news, but in some sense, if the infection fatality rate is 1 in 1,000, it's not as hard as it would have been if it was 3 in 100 or 3 in 30 in 1,000. But in any case, so if let's go back to Sweden and Norway. If you look up to now and say, okay, Sweden's done worse with the number of cases because they haven't locked down, that's true, but that's not the relevant number. The relevant number is once the lockdowns lift in Norway, what will the case numbers look like there, right? And then the other side of the debate is that the lockdowns are not costless. Like, people think about lockdowns as if they're a safe alternative, but they're not safe. And I've seen this mischaracterized over and over again. It's not simply the case that you think about the economic harm from the lockdown, because it's actually deaths on the other side of the lockdown as well. People delay chemotherapy. People delay. There are reports of people having heart attacks not coming in. Delayed vaccinations of kids. I mean, there could be, if there's enough of that, then you get a measles epidemic next year. I mean, you get a lot of what you would call it, maybe you wouldn't call it essential, but I would call it essential healthcare, even though you may be allowed to do, people are just too scared to get it. So I think a lockdown have those like immediate medical effects, but it also has the economic harm from the lockdowns, which essentially are a global depression that I mean, we already started it, and it's likely to, I mean, it seems like it's likely to continue for a while. That has enormous negative effects on the health of poor people everywhere around the world, especially in poor countries. In the UN, there was a report about I think it was like 500,000 kids likely to starve as a result of the global economic collapse. I mean, as a moral people, we need to include those lives in our calculus about what the right policy is. So I don't think it's right to just look and say, okay, Sweden's done worse up to now. Okay, we've now counted the benefit of the Norwegian policy or the American policy, but we haven't counted all the costs, and we certainly haven't counted all the costs in the long run. And then I think the long run is, unless we come up with a very fast vaccine or a very fast, very effective treatment, then essentially Norway's bet won't pay off. America's bet won't pay off. We're going to pay the cost of the high COVID deaths anyways, unless the treatments arise very, very rapidly. But we will certainly all pay the cost of the economic harm and the depression that's coming.
So a couple of things come to my mind as we're talking about that. I mean, we talk about where do we go from here, and I'm thinking we've identified data points. The science tells us that there is a specific population, or there are specific populations that are far more at risk than other populations, and so the question would be, do we then protect those hot spots, if you will, and anticipate them, protect them, and go about our business and see if we can overcome the virus through herd immunity on one side, and on the other side, we're protecting and isolating where possible those who are vulnerable.
So I completely agree with it. My mom's 80. I want her to survive. I want her to live. I want her protected. But I also want my kids to be able to learn and go to school again. I mean, I think that's very, very important that we have both of those. The herd immunity, I'm a little careful about, because we don't know enough about the immune response to say exactly how extensive that would be. I mean, certainly there's some immune protection, that's clear. But how to measure that immune protection and how extensive it is, or how long lasting it is, or how complete it is still a matter for significant scientific debate. And I think we should understand that there's still considerable uncertainty around that. The long run is probably herd immunity, but we're very far from that, is what I'd suggest. That Santa Clara 3%, in LA 4%, even in New York is only 21%, nowhere near herd immunity, or 25%, whatever the number is right now, in terms of the population that's been infected. So I think thinking about let's wait until herd immunity is also not quite right? Because that's going to be, it's just like a vaccine, a very long time away.
So one of the things I hear often is that schools should open up, because the odds that any of these kids get, let's talk about the students age K through 12, for instance, that the data seems to say that they are far less at risk than, say, even a healthy 40-year-old vis-a-vis an 80-year-old with a couple of comorbidities, and that the number of fatalities within that range of K through 12 is virtually non-existent, unless there was some additional health issue already present. What's your thoughts on that?
Yeah, I mean, I think that you're absolutely right, Congressman. I mean, I think that there's a lot of evidence that kids are in some way protected from whatever immune response they have, seems to protect them from the worst consequences of the virus. In fact, there's this very fascinating study out of Iceland where they've actually sequenced the genome of a very large fraction of the number of cases that they've had of the virus, and they've tracked mutation spreads. Right, so you can tell if person A got it from person B because they share the same mutation of the virus. And what the report was really interesting is like there's not a single case that they were found where the kid passed the virus on to to an adult. It's always the other direction. I mean, so it's clear there's something about how children react to this that protects them from the viral spread.
And I asked this next question just because I'm wondering about poverty. I'm sure weighs into somebody's development of their how do we say this? Their
immune function,
immunity function. So I guess what the data you were just talking about, it's regardless of whether the child was poorer, or richer, right? I mean, that seems to be consistent across.
There are really sad cases of kids dying from this virus. I don't mean to diminish that, but as a population as a whole, the death rate is much lower among infected kids than among infected 80-year-olds, say. So I think there, but you mentioned poverty. That's actually does play a very important role in this epidemic. I think so. For instance, in the Santa Clara data, we found that poor populations actually had higher rates of previous infection, right? So it's clear that there is, just like with almost every health outcome that you see, or not just the U.S., around the world, there's socioeconomic status gradient. Right? The poor have it worse than the more well off. I think, it's interesting to try to understand that. I don't fully understand it myself at this point, I'd say. But I think at least part of the explanation must be the living situations of the poor make it so that you're more likely to pass the virus within those living situations. The jobs that the poor have are more likely to be maybe public facing, so you face more risk from exposure to the virus. It's got to be some combination of things like that that explain why you're seeing these patterns.
Well, Doctor, before we go, I want to first of all thank you again for taking time out. It's very informative, and then I want to thank you for your work in this area, and just, I mean, I told you very clearly, we just want to go where the science and the data shows us. As we get ready to wrap up, please tell us what you're working on specifically and what you hope to find out, and the importance of it.
So right now I'm trying to wrap up a study of Major League Baseball employees. So mainly not athletes, actually, just folks who work for Major League Baseball. It's we collected this data on the antibody prevalence study about a couple weeks ago, and we're trying to figure out sort of patterns across the country. It's the first study of nationwide scope. It's obviously not representative of everybody. It's a Major League Baseball, but it's still interesting because basically in 27 to 30 cities around the country, in a single snapshot, we're going to be able to see into how widespread the disease is. So we should have that wrapped up hopefully this week. I teach 2 classes at Stanford, so I've continued to do that. And I'm also trying to get some work going on trying to understand clinical correlates, because in places where you don't have a lot of testing, actually it turns out there are some things that uniquely identify that signal that you have the virus and not just a regular cold. Things like loss of taste, of sense, and smell. So I'm trying to do some clinical work. The other thing I'm working on is some more seroprevalence work in India, in some of the slum areas of Mumbai. Because this is not just an American phenomenon; it's a global one, and I think these seroprevalence studies kind of need to be done everywhere.
Wow. Well, you know what? I thank you. I know you're really busy. Thank you for your time. Thank you for what you're doing, and when you get the baseball study done, believe me, I would like to take a look at that. Probably just the summary for me, but I mean, I still would like to look at it.
Congressman, it's been a pleasure. It's been fun to talk with you about this.
Thank you. The best to you and your family.
Thank you. You take care.